Good afternoon. This is August 30th, 2017. We are recording for the first exam of IT2A. Me personally, W. Hussein, and we have Paulos who's talking. Disclaimer, there's some mistakes on the slides in terms of category pregnancy issues, as well as a disclaimer for use this information at your own discretion. This should be a supportive information in terms of understanding concepts and clarifying any issues with the topics we're covering for the exam tomorrow in IT2A. Starting with penicillins, we have penicillins that are natural. Penicillin G, potassium, and sodium. They come in 2 to 4 million units every 4 hours. We also have penicillin VK, which is oral. And we also have penicillin G in the forms of procaine and bezathine. Natural penicillins are available IM and IV for penicillin G. VK is for oral. These do require renal adjustments. Note that the side effects you'll see repetitive in terms of hypersensitivity, hematological effects such as leukocytopenia and thrombocytopenia. You'll see nephritis, seizures. These kind of falls under all the beta lactam families, which are penicillins, carbapenems, penicillins, carbapenems, and cephalosporins. All the beta lactams will have the same side effects across the board. Again, those are hypersensitivity, hematological effects, nephritis, and seizures, so on and so forth. Category B for pregnancy. This category of penicillin, natural penicillins, are good for syphilis, streptococcal, meningococci, pneumococci, staphylococci, and treponema pallidum, which treponema pallidum is what is the culprit that give rise to syphilis. Enterococci, note that it's not a good coverage. Actually, it's a moderate. If not, you could just think of it as a no coverage for enterococci in terms of when you look at natural penicillins. And then, do you want to go through each category or finish penicillin? Then you go.
No, just a few facts on the penicillin.
Okay, so once I cover natural penicillins, Paulos will point out the things that stand out for natural penicillins, and they'll be for every category as we go on.
So just to recap about just the background information on penicillins, note that not just penicillins, note that the beta lactam as a class, including penicillin, cephalosporin, and carbapenems, they're going to be time-dependent killing. So comparing that to with the fluoroquinolones or aminoglycosides, these are time-dependent. Not concentration-dependent. With your natural penicillins, you're gonna have short half-lives, and therefore you're gonna be required to dose them frequently. So whether that be every 4 hours, every 6 hours. When you're moving from your penicillins to your cephalosporins, you start to see the dosage change to every 6, every 8, and every 12. Some are even dosed every day. And with all the beta lactams, if you're dosing something at a high concentration, you're gonna be more likely to experience seizures. So that's the other thing. Seizures are gonna be a factor, especially in the carbapenems, but at a very high concentration. The beta lactams, they all inhibit the PBP, penicillin binding protein, and again, they're gonna be eliminated renally, just to kind of everything tied together.
So that's the similarities for all the beta lactams across the board. Next class, as you can see, natural penicillins cannot cover. It can cover staphylococci, but resistance has built up to it. Therefore, the anti-staph has been created, which are nephcillin, oxacillin, available at 1 to 2 grams IV every 4 to 6 hours. Dicloxacillin, 250 to 500 by mouth 4 times a day. Hepatic adjustment is required for this class, not renal. That's a mistake. Hepatic adjustment is required for this class. ADR, again, hypersensitivity, nephritis is repetitive. Something that stands out here is hypokalemia, which is seen in nephcillin, penicillin. You also see rise in LFT elevation. Well, that.
You did natural penicillin first?
Yeah.
Okay.
You see rise in LFT elevations. Well, that makes sense because this class of drugs runs through, or this subclass runs through hepatic clearance. So the liver is probably working hard or being overloaded with these drugs. Therefore, you see a rise in LFT. Category B for pregnancy. Note that nefcillin also is a CYP inducer. It is good against MSSA because it's an anti-staph category, but it doesn't cover gram negatives yet. No enterococci, no anaerobes, MRSA, and so on.
I thought this whole group covered MSSA.
Yeah, it does cover MSSA, but the gram negatives, enterococci, the anaerobes, is no coverage still. So as you can see, gram positives are covered, and things are kind of added one at a time.
But you said only nafcillin covers MSSA,
No, the whole class is anti-staph,
right?
so
Yeah.
they cover MSSA.
Yeah.
So going back to penicillin, the one thing we didn't mention about penicillin is penicillin G, specifically benzathine, is the drug of choice for syphilis. That's the one thing we didn't mention. The way to think about these drugs, especially for the penicillins, is when you're going from your natural penicillin to your anti-staph, anti-amino penicillins, you're adding something and you're getting something from it. So in the natural penicillins, you had good gram-positive, but you don't have any MSSA activity or you don't have any enterococci. So take that into the next class. So now when we're talking about the anti-staph, we still get that gram-positive activity, but now because the bacteria have figured out a way to kind of become resistant to the drug by producing beta lactamases, natural penicillin would be ineffective. So what the anti-staph would give us is they give us beta lactamase coverage. So if your bacteria is producing beta lactamases, you can use these drugs, the anti-staph. And these again are the drug of choice for MSSA. Some notable side effects include hypokalemia with nafcillin, I think also with oxib, but don't call me on that one. What else? Yeah, that's it.
Okay.
Oh, so with the anti-staph, this might be like on the side, but with the anti-staph, again, because you're dosing it frequently, and especially if you're giving an IV, you're gonna get something called phlebitis, which is inflammation of the vein. So again, that's another limitation to using these drugs, because if you're giving a drug every 4 hours, then you're gonna start inflaming your veins. So you're gonna look for alternatives, and we'll see what that alternative is.
Would that be all for all penicillin? Because they all
Yeah.
have short half-life.
Yeah, I mean, the book specifically talked about this class of penicillin. So, I mean, theoretically, yeah, if you're dosing something, if you're giving it something for every 4, yeah.
So yeah, penicillins are given, as you can see, very frequently, every 4 to 6 or every 6 hours, because they have very short half-lives, which is almost 2 hours or even less.
And in terms of the dose adjustment, you don't need to make renal adjustment. However, if your patient has both renal and liver issues, impairment, then you have to consider dose adjustment. But if your patient just has renal, you can let it go.
Aminopenicillins, we have ampicillin 250 to 500 milligrams every 6 hours by mouth. IV form, then it's 1 to 2 grams every 6 hours. Amoxicillin 250 to 500 every 8 hours by mouth. As you can see now, there's a trend of 250 to 500 ranges of dosage. Root ampicillin can be given IV, IM, or by mouth, where amoxicillin is only by mouth. Renal adjustments are required for aminopenicillins. Again, renal adjustments, like Pablo said from the beginning, you'll see all across beta lactams. ADR, same side effects to cut short and move faster. The only thing that's notable here is probably diarrhea. It's definitely seen in aminopenicillins. Now, coverage, what's been added and subtracted is that enterococci is now covered in this category. What's not covered anymore now is MSSA. And gram negatives are still not covered in this case. Anaerobes are still not covered. Because the fact that it can cover enterococci, ampicillin is a drug of choice for enterococci.
You can get anaerobic coverage because
For this one?
usually when you're she said that amoxicillin and ampicillin they're given, but they're always like
Oh, was it on the star? Ampicillin and a star, right?
not ampicillin by itself. If you give ampicillin with a beta lactamase inhibitor, then you actually get an additional coverage.
That was one with the asterisk at the coverage slide.
I don't know if it was asterisk, but
Yeah. It was right here. Anaerobe. Oh, it wasn't here.
it should be there.
Oh, yeah, right here. Ampicillin
Yeah,
with
sublactam.
sublactam.
So
Okay.
Yeah.
So correct me. ampicillin can actually cover anaerobes if given in combination with
Right.
a beta lactam. Oops, wrong slide. Okay.
You good?
Yeah.
Okay. So again, just taking it back. With the natural penicillin, we got syphilis. With the anti-staph, we got MSSA. But we still have not had enterococci, and we still have not had anaerobe. And the aminopenicillins, that's what they did for us. Because the drugs, the structure of the drugs can actually cross the point and the channels of the for the cell walls of the gram-negative, we can actually use some of those drugs to treat, not to treat, but it gave us a gram-negative coverage due to the structure modification. So now the aminopenicillins are going to be a good choice of drug for enterococci, right? Because we added that enterococci coverage. These are going to be a drug of choice for listeria, right? When we talk about enterococci, we talk about two families or two subspecies. We talk about the enterococcus. Somebody pronounce it for me.
Faecalis and facium.
Faecalis and facium. The enterococci faecalis is almost always susceptible to these drugs, meaning that the drugs can treat it. The Aminophilus enterococcus facium is often resistant to these drugs, and I think we talked about a drug that actually covers facium and doesn't cover faecalis on just this week, right? Yesterday. So now again we have two drugs. We have amoxicillin and penicillin. Both of them can be PO. Amoxicillin, if you look at the dosing, you dose it every 8 hours, and that's because it has a really good bioavailability. So if your patient is taking ampicillin IV and you're discharging the patient, send them home with amoxicillin PO because it has good bioavailability. Both of them you do adjust for renal, you adjust at 30. Okay? And if you couple the aminopenicillin, the ampicillin with beta lactamase inhibitor, in this case a sublactam, then you get an additional coverage. That additional coverage here would be anaerobes. So when you have ampicillin with sublactam, or you have amoxicillin with clavulanic acid, you get anaerobic coverage. Moreover, when you add the beta lactamase on unison, you actually get what? Acinobacter. Okay? So the fact that you're adding all these things, you actually get more coverage. You're broadening your coverage. Does that make sense? Okay? Again, you renally adjust at 30. Know that enterococci is the big player here that we added. We also added some gram-negative, and we added anaerobes. Okay? But we still have not added...
And then one got taken away.
The MSSA. But we still have not added what? Pseudomonas, Vicero. Even though we added some negative, we would not use the aminopenicillins to treat gram-negative pathogens. Right? So we're still missing something. So that's why I keep saying, like, keep it a story. Tell a story.
That's what I'm doing right now.
Okay. So what's Spicea again?
I kept it as Enterobacteriaceae family.
Spicea is just gram-negative bacteria. So your Serratia.
Each one has a definition, yeah.
Yeah. Serratia.
Each one's a definition of
gram-negative. Which one's Spicea?
Yeah, the Proteus, yeah.
Serratia, Proteus.
All of this?
Something like that.
This is here. This right here.
Escherichia coli, Citrobacter, Enterobacter, Klebsiella.
That's right here. Shigella. I don't know. That's all I know.
Morganella.
So you're saying with aminopenicillins we had MSSA,
We don't have MSSA now.
but we don't. It's
Anti-staph was MSSA.
yeah.
That's that. You don't want to think about it like that. Think about, okay, what did that class of drug gave us? What was the major contribution for that class of drug?
So basically,
For
Anaerobes, right?
anaerobes and what?
Some gram-negative.
Some gram-negative, but we added what? Enterococci.
that was the main.
So that's
thing.
the big thing.
Yeah.
Like we can analyze the specific pathogens, but we need to know what got added in each class in order for us to move on and like go specific into the different pathogens. So what got added, what got subtracted. That's it. Okay. And then
Which ones are the anaerobes?
the anaerobes are unison and augmented.
No, that's the coverage from, that's the antibiotic, but what is the
It's in
coverage, like what's the actual bacteria? Like it's bacterioids or is it Clostridium?
It could be Clostridium. Clostridium is anaerobe.
Yeah, that's
There's Clostridium, there's B fragile, there is Vilonella and Actinomyces.
okay, for
Okay.
aminopenicillin.
Those are gram-positive.
Not for aminopen. I'm just telling you that these are the anaerobic pathogens.
Right.
I don't know if they can treat C. diff. I wouldn't choose aminopenicillin to treat C. diff because they cover anaerobic pathogens. You see what I'm saying? That's why I'm like, it's hard. Like right now we just like that's our first week. You know. Like,
Continue.
I mean C. diff. What would you treat C. diff with?
So just for C. diff, the ones that can treat anaerobes.
Like maybe you can use Vanco. Vanco treats C. diff, right?
This is but it's a drug of choice that does C. diff.
But would you use amino to treat C. diff?
Aminopenicillin? No, it's a better drug.
That's what I'm saying.
Yeah.
You see what I'm saying? Like there's better
Everything that stands out, you make a star and like, hey, this is a drug. See,
Right.
right now I did this drug choice for enterococci. It's the same statement for C. diff somewhere else.
We have natural penicillins that are going to be gram-positive, gram-negative.
No. We don't get gram-negative activity with natural
Gram-negative
penicillin.
cocci. And meningitis.
It says some.
and
It said some gram.
Yeah, like some gram-negative. And then
Okay.
for just
But the big takeaway
So
from
here,
the natural
yeah,
penicillin
wait.
is what?
Yeah.
She will say it, and then she will say on the slides she will say some gram-negative, but she'll tell
Right.
you it's
Which
not
one?
the go-to drug.
Exactly.
right.
So just
Yeah.
know what the go-to drug.
Yeah, those if it doesn't stand out, it's not worth memorizing. This is enterococci, it stands out. That's what we see. That's what stands out. MSSA stood up for anti-staph. Aminopenicillin, enterococci stood out for us.
But what stood out for you for the natural penicillin, Pfizer?
Gram-positive.
All of them have gram-positive.
Okay.
What stood out to you the most from the penicillin?
Streptococci.
Sorry.
meningitis.
That's still gram-positive, but give me a specific pathogen that causes. I want the pathogen too. We forgot to mention the pathogen. What was the one thing we used 10G benzathine for?
Syphilis.
Syphilis.
So
That's the-
Treponema pallidum.
Bingo. That's what stood
Alright.
up. That's what stood up for us. Syphilis.
Continue.
Yeah, Dobie, how do I call in for my barber?
What do you mean call it?
Come tomorrow.
Tell them your schedule. It's
Not
better to
tomorrow,
schedule now
Friday.
and tell them what's up before you are late.
You going to Jesdy?
No. Okay, continue.
They're just coming to the barbershop.
Alright.
What covers Actinobacter? Acinobacter?
Now,
What was that again?
what's on the right side? Huh?
That's ampicillin.
Penicillin, beta lactamase inhibitor. What's on the right
You
side?
said what?
Yeah.
On the right side.
Oh yeah.
So we've seen now the coverage as it continue. We've seen stuff that stood out in terms of side effects. Now, when we see penicillin / beta lactamase inhibitors, now beta lactamase inhibitors were combined with ampicillin, amoxicillin, just the previous class we just talked about, because now bacteria got resistant. They had beta lactamase enzyme that starts slicing up the antibiotics. So now when we add beta lactamase with ampicillin, they don't technically they're not actually making it
Ampicillin?
bind. It's not like actual drug that makes it itself active, but they increase the activity of ampicillin and amoxicillin, and they're also increasing the spectrum of ampicillin and amoxicillin. The sublactam and the clavulanate are the beta lactamase inhibitors. The dosing for unacin 1.5 to 3 grams IV every 6 hours. Augmentin is 500 per 125 3 times a day, or is 775 per 125 twice a day. This should not be 875. It is 775.
No.
No,
That's
No, it's 875.
the one is 775.
If your patient has a renal clearance below 30, you should not give them 775 milligram of the immediate release or the extended release. The 875, that's right. That's the right dose.
Then why not 875 then if they have renal?
You can, I don't know.
I mean, if you're not giving
Why 775, you know?
then why Why
I
would you
think
use
it's
A75 if you're not
She
even
meant-
giving
she
some?
meant-
Why even say 775?
Nah,
You can't
that's
even give
875
A.
as far
That's
as what they
pharmacy,
sell.
yeah.
Yeah, you go through
That's
that like
standard.
yeah, you go through that like freaking water.
See, that makes sense to me to say not don't use 875, but then she says 775. Like, what?
That's because it's probably the immediate release. There's extended release and there's immediate release. I'm not sure.
Oh, 725. I've never seen that.
I'm never. Yeah, that's just one of those things you just
Okay.
take with you.
That part.
If there's a renal adjustment required below 30, then you don't use the highest dose. Not even the 500. You use the lowest form, 250 to 500.
I'm gonna ask him.
The same doses. What changes is the intervals. Okay, every 12 hours versus 3 times a day to once daily. HD is hemodialysis. ADR, nothing to take out from. Category B. Now the coverage. Now previously we didn't have MSSA. Now we got back MSSA. We kept enterococci. Strep is still there. Some gram negatives, but no pseudomonal activity, and still no spice A organisms. Acinetobacter, which is a gram negative, which makes sense when we say some gram negatives, unacin can cover this, not augmentin.
So you saying
There's no spice A?
the
What's spicy?
the regular aminopenicillin doesn't have MSSA, right? Only anti-staph does.
Yes.
But this one covers MSSA.
Yes.
With the anti-beta lactamase.
Yes. So now we have MSSA again and enterococci, but still nothing against the major gram-negative organisms. Acinetobacter is kind of something that's a caveat that you want to memorize. Yeah, Unison can cover Acinetobacter. Used against intra-abdominal infection, gynecological infection, pneumonia, lung abscesses, SSTI, and so on and so forth. All right.
Amoxicillin has atypical coverage.
Ampicillin.
Ampicillin, I'm sorry.
Ampicillin? I haven't seen atypical until way down.
She has atypical as a ampicillin.
Atypical first brought in was with fluoroquinolones.
Yeah,
Now you see on the slides?
but there's a caveat to it though. Right there.
Oh yeah.
Atypical.
Bottom right.
Ampicillin, yeah. So that's why I didn't want to put it as a atypical because it's a
There's an exception.
exception, which I don't know what the exception was.
If it's a combo, maybe.
That's what I was
Are you still
thinking.
recording?
That's the only way it could be atypical if it's it's still recording. The only
You
way
should have put. You didn't put ampicillin. You should
Ampicillin
have
with
put
the club, whatever.
unison.
exactly.
Amoxicillin.
Definitely ampicillin will not cover atypical by itself. Cause look, atypical by itself it couldn't cover enterococci.
Or anaerobes.
Yeah.
I don't know. I wouldn't. I don't know. I wouldn't characterize that having atypical coverage because we actually have drugs that's their goal. Like,
Yeah.
Atypical is their thing.
Right.
So rather than learn about drugs that have exception, this and that, like there's drugs that are definitely the go-to.
Right.
So let's learn that first, memorize that hardcore, and then we can the exceptions comes in later.
Memorize that.
Okay.
Tell a
Oops.
story.
You recording the screen
Yeah.
and the voice?
Yeah. Okay. Go ahead, close.
I don't have anything.
Okay. So keep in mind, we still haven't covered pseudomonal activity nor spice A. So what do we got to do for the next categories? Let's get some activity for pseudomonas. So anti-pseudomonal ES, which means now we've extended the spectrum of these drugs. Piperacillin, tazobactam, called Zosyn, and tecarcillin with clavulanic acid, called Timentin. Zosyn comes in 2.25, 3.375, and 4.5. The regular dose is 3.375 IV every 6 hours. If it's an infection that's serious or if it's actual Pseudomonas itself, we give the highest dose, which is 4.5. Renal adjustment is required. Again, we have seen renal all across except for anti-staphs, right? But everything else so far has renal adjustments. Renal adjustments required for this category, so therefore you give the lowest dose that's available, which is 2.25. ADR, nothing to take out except that it's a hypernatremia. Category B.
Specifically, hypernatremia is specifically to what? It's a specific. It's not both tazobactam, Zosyn, and Timentin. It's one of them specifically.
I don't know what the MOA is.
As what? As Zosyn.
You ask her why?
It has a high sodium content.
Really?
Mhm.
Okay.
I mean, the bag itself That's what I'm assuming. The bag of stuff contains a lot of sodium.
Well, same thing with Tibenton. If you're gonna put it into a sodium saline bag, it's something about the MOA in the body.
I don't know if it's the MOA. She said it contains a lot of sodium, specifically zosine.
So zosine itself, the structure.
I don't know if it's just structure or the thing they mix it with. I don't know.
So
Hypernutrition.
she didn't explain very well.
Whatever the case may be, if your patient is hypertensive, just watch out. That doesn't mean they can't get it.
All right. Gram positive, gram negative is there now. Anaerobe is added, which we haven't had that before, except in the ampicillin.
Don't say it. Make it a conversation.
I'm asking you.
You
Yeah.
answered it.
Oh, okay. I was checking. I didn't know. I forgot. We've seen anaerobe and ampicillin only if it's given with a combination. Pseudomonas now is finally covered, and most spice A, which are the major gram-negative bacteria, fall under the Enterobacteriaceae family. So you guys should know what spice A should stand for. If you don't, look it up. It's used for Pseudomonas, obviously. Nosocomial infection, bacteremia, pneumonia, and UTI. So Pseudomonas, gram-negative. Nosocomial infection, hospital-acquired infection. Pneumonia, gram-positive. UTI, we've seen that in gram-positive and negative. So many pathogens can cause UTI. Follows?
Okay. So these drugs are so good, okay? Because they give you a lot of coverage in terms of anaerobic coverage, gram-negative coverage, gram-positive coverage. These are like your go-to drugs when it comes down to empiric therapy, right? They're rarely okay. So zosine and timentin, okay? They also gave us Pseudomonas. Why? Because they're a class of drug that's known as anti-Pseudomono. So it makes sense that they gave us Pseudomono coverage, okay? These are again good for upper and lower respiratory tract infection. Again, gram-negative, gram-positive, anaerobe, Pseudomonas, and spice A. So we have, this is a good drug to use, and again, this is renally adjusted at 40. So so far we have
34 aminopenicillins. Then we had renal adjustments for penicillin and beta lactams inhibitors, starting at 30. Now we have renal adjustments requirements for anti-pseudomonas at 40.
Yeah.
So 30, 30, 40.
30 for anti-stuff.
Yeah, I mean, the 30 is for the aminopenicillin as well as the aminopenicillin with beta lactamases. So you can just know one.
It makes sense, yeah, because they're both there's ampicillin in both.
Yeah, that's what I'm saying. And then for your anti-pseudo, it's 40. That's it.
All right, that's it.
No, we're not done with the carbapenems. I mean, the beta lactams.
No, I'm saying it's.
Yeah.
Yeah, okay. I don't know how to pause recording if you have to pause.
At the top, no? Hover through your right there, right?
No, that's completely stop.
Why do you want to pause it?
Cause it can be one video.
Oh, just stop it then. Are we not done with the beta lactam? So don't pause it yet. I think she had other things in this lecture.
Oops.
Does she have the carbapenems in here? Or no?
Yeah. Well, I don't know. I mean, I have it.
So this is it for the first lecture?
I don't know. I just continue, bro. I just continue.
No, just stop it. Stop it.
Beta lactams.
No, we still have more beta lactam left.
Yeah.
Seth, right here.
Okay, yeah, so let's continue.
We're still in beta lactams. So we'll after talking about all the beta lactams, we'll cut the video and start a new video for the new set of drugs. So
The atypicals.
Is good, Faisal? Austin?
Yes.
good.
Good.
Okay. So now we've seen all the penicillins. We've seen how they trend, their doses, their side effects, as well as their coverage. Now we're gonna switch to cephalosporins. There's 5 generations. First generation, we have Keflex, Ancef, and Cefadroxil. Keflex, cephalaxin, 250 to 500 every 6 to 12 hours. Same kind of dosage range we've seen for penicillins. It can treat laryngitis, streptococci, UTI, and then SSTI. SSTI is skin and structure infection. Soft skin and tissue infection. Cefazolin and Cef, 0.5 to 1 gram IV every 68 hours. If it's severe, you up the dose to 1 to 2 grams every 6. You'd be given IV or IM. The first gen is commonly reserved for surgical prophylaxis. It's the most common indication for surgical prophylaxis. It is good against MSSA, Streptococcus, moderate gram negative, but no enterococci, no anaerobes, no MRSA, no pseudo. Now you can kind of see that we've kind of starting from the bottom scratch, just like how we do with penicillin. As we continue with generations, we're going to add on to the coverage. So kind of like the same trend, the same kind of thought process we're trying to go through with the Cefs, as well as with we did with penicillins. Go ahead.
So you have two PO drugs in this class. You have the ceflexin, which is called the Keflex. And you have the cefjoxil, which are your PO, another PO. You have the cefazolin, which is the IV, which is called Ansef. Now, Ansef is going to be the drug of choice in severe MSSA cases. Okay? But usually, the first generation are mainly used for what?
Streptococcus.
Streptococcus, okay.
Gram-positive.
Okay.
MSSA.
No.
What was the question?
Surgical prophylaxis.
There you go, bingo.
was the
Surgical
question?
prophylaxis. Usually the first generation
Oh,
are
yes,
used
yes.
for surgical prophylaxis. Again, I told you guys with the anti-staph, one of the side effects was what? Like not the side effect, but one of the downside of using anti-staph was what?
Seizures?
Mm,
Or like,
I mean, all of them can cause seizures at a high dose, I said. But there was something caveat that I told you we're going to come back to that. How often are you dosing these penicillins?
okay, 6
Frequently.
Yeah.
That's the catch, right? So the anti-staph, because
Is it
you're
the vein, the
bingo,
phlebitis?
that's it, phlebitis. So
You
because
got that from the book, right? She didn't talk about that in class.
yeah,
You got that from the book.
the book.
Okay. Just next time, just throw that in there. Because she didn't know what you were talking about.
Oh, I was under the assumption everybody reads the book.
I still know what you're talking about.
Okay, well, this is from the book. So these will be a good alternative to the anti-staph because they cause phlebitis. These one you're dosing it a little less, so you might not see that vein inflammation that you see with the anti-staph drugs. Yeah, and IVIM as the route. Next.
Second generation, we have 5 drugs, but we only will talk about 3. We have cefuroxime acetal, which is the Ceftin, that's oral. Cefuroxime sodium, Zinacef, that is the IV form. This is the only drug in this generation that can cross the BBB, but not well enough to be used as the drug of choice for bacteria that can cross the blood-brain barriers. Although it can, so therefore it can treat Haemophilus influenza, which is a pathogen that can give rise to meningitis, sepsis as well. Infection can be used to treat this, to be treated with the drug. The next 2 drugs, cefoxitin and cefotetan, these are very distinctive drugs in this class in the fact that they are IV and they are given for anaerobes. Okay. Gram negatives as well, but no pseudo. So therefore they're good for UTI, PID, gynecological infections, intra-abdominal infections. Makes sense because especially with PID, which is pelvic inflammation disease, and intra-abdominal infection, those environments are oxygen deprived. Therefore, it is a good environment where bacteria that are anaerobic, they can thrive in that kind of environment. So these drugs are good to use to treat those type of infections, specifically anaerobic infections. ADR, you can see side effect that can also stand out is the INR increases. This is because cefotetan is part of a class called cefamycins. You should know cefamycins include cefotetan, cefoxitin as well, and one more which we haven't covered yet. These class of drugs, cefamycins, they have a structural feature where it basically allows them to inhibit vitamin K, therefore have the INR increase and as well as make some drugs ineffective, such as warfarin. So that also something that stands out that you should memorize. So as a class, second gen, they're good for some enteric gram negatives, Haemophilus, influenza, and Neisseria, but no enterococci, no MRSA, no pseudo, still up to this point.
So Anacept, is that the only one for surgical prophylaxis or the whole first generation?
The whole
Honestly,
first generation.
No, I mean, how are you gonna give somebody a PO drug if you're undergoing surgical prophylaxis?
That's true.
No.
Unless you're giving it like 2 days. in
Yeah,
advance.
no, because they come in for the dentist and
You
they
believe
come
that
in and
too,
get
Yeah.
they start their antibiotic
But I
treatment.
would just memorize first gen as a surgical prophylaxis. So
First gen, the whole first gen?
specifically, it did say ANSEF in the book, I believe. Yeah, because it's given IV. So, all right, pause.
Okay. So again, the second generation, they gave us a better coverage compared to the first generation. What does that mean? What do I mean by that? So they gave us a better gram-negative activity. They had good gram-positive activity, but they gave us gram-negative activity and they took away a little bit of gram-positive activity. Now, in terms of the specific drugs, Dobie mentioned that the cefamycin, cefotetan, and cefoxitin, those drugs gave us something unique, and that is the anaerobic coverage, right? So this is when he's talking about intra-abdominal pelvic infection, we can only use those drugs because they gave us anaerobic coverage. Now, so these are used in UTIs, pelvic inflammation, and again, cefotetan can cause increase in INR. To go back to the cephomyces, this is from the book. It says that because that these have the NMTT ring, I think this is for the cefotetan, this can actually cause a disulfiram reaction if taken with.
Yeah, so cefamycin, all the drugs that are under cefamycin has the NMTT side chain that inhibits vitamin K, can cause disulfiram reaction as well with alcohol. So two things, inhibit vitamin K and disulfiram reaction.
Yeah, cefotetan, so there's two caveats with cefotetan. Cefotetan causes an increase in INR, and cefotetan, if taken with alcohol, can actually cause disulfiram reaction. Just like one of the drugs that we're going to talk about later on.
Metronidazole. and
Bingo.
There's another one too. That
So cefamycin, again, does not include cefoxitin, it's cefotetan, cefamondel, and cefmetazole. But cefotetan, just know that drug for now.
Yeah. And okay, so quick recap. So we've seen anaerobic coverage for a few drugs, right? So let's just recap. So what gives us anaerobic coverage?
Second
So
generation.
go from your
cephalosporin.
penicillins.
Oh.
No.
Is it anaerobic?
Aminopenicillin with beta lactams. So give me the drugs.
Unison.
Unison and
Is it anaerobic or anaerobic? Aerobic.
it doesn't matter. Anaerobic coverage.
Is it anaerobic? Okay, yeah. So the
Unison is one.
Amoxicillin and
augmentin.
Augmentin.
What is that?
That's amoxicillin and clav.
Oh, you said amoxicillin and clavulanic acid.
Yeah.
Augmentin. Okay. Now go down the list. What else? What else gave us anaerobic coverage?
Zosyn.
Zosyn gave us coverage. Anaerobic coverage.
And what about the other one too? No.
Mentioned?
Yeah.
I'm not sure. I think.
I mean, I figured with
Yeah,
the. I figured with the.
Lauren, this is being recorded by the way, so just a
Yeah.
disclaimer. No, you can talk. I'm just telling you that.
You said
Just
anti-cinnamon
censor
on
it.
what else for the penicillin?
Okay, got it.
You
What?
said anti-stat, right?
For what?
No, aminopenicillin.
For
Combo, sorry, for pseudomonas, or anaerobe.
anaerobe, we gave it so unison and augmentin. What else do we have? Zosyn and timentin.
Right.
Now we finished our penicillins, the whole penicillin. We went through it. Now let's go to the cephalosporin. So first generation gives us anaerobic.
No,
Second generation,
yes.
which one gives us anaerobic?
Cephalosporin,
Which are called?
cephomycin.
Bingo. That's it.
So anaerobic, we said it was only seen in Zosyn's,
Zosyn,
The-
unison.
the anti-staph. Unison because it was
Not
combined.
anti-staph. We didn't see
Sorry,
anything.
anti-pseudo.
Yeah.
Anti-pseudo.
Anti-pseudo,
And
ampicillin
combined.
because it was combined. And what
Both
else?
of them.
Unison
Both unison
and
and augmentin.
Okay, okay.
Yeah.
And now we in gen, exception.
Mm.
So we talked about drugs that can cover anaerobes. Just for an example, we've seen anaerobic coverage in anti-pseudomonas drugs. We've seen anaerobic coverage in beta lactamase inhibitors with penicillin. Now we see it in here in the second generation of ceph with which are cefoxitin and cefotetan. Is it? All right. Continuing on.
Is it hot or no? It's good?
I'm solid.
Let me know when you plug it in.
Third generation of cephalosporin. Now, this whole generation stands out because they can cross the BBB. Okay, specifically Rosulfan, Cleforin, and Fortes. These are brand names because I'm saying them by name because we should know them. Highest, they have, this is a typo right here. It should be, what is it? Lowest activity against gram-positive. Highest, huh?
I don't know if I would characterize it like that.
Yeah,
Let
it's,
me look at
it was on our slides.
Oh, okay.
Against gram negative, I thought.
So in third generation, now we're increasing the spectrum towards the negative and less from gram-positive.
Yeah. You
Right?
get less gram net positive. Yeah.
So there's low gram.
Did she say, did mine say excellent gram negative?
It is for third generation. Yeah.
Third generation, we are increasing gram-negative coverage, less with gram-positive. It has really high good resistance against beta lactamase. Ceftriaxone and cefotaxime are approved for meningitis and pneumococci that arise from meningococci as well as H. influenzae. First drug, Suprex, cefexime, given 400 milligrams daily. Renal adjustment is required as usual with all the other drugs like penicillins. Category B, ADR, not much to talk about, is used for acute bronchitis, otitis, pharyngitis, gonorrhea, as well as gonorrhea can cause STD, and then there's also UTI. But note that Suprex does not cover, does not cross the BBB. Cleforin, cefotaxime, can cross the BBB, therefore it's also a good candidate to treat meningitis.
Mm-hmm.
Rosulfan, ceftriaxone can cross the BBB. Dosage 1 to 2 grams daily. If it's a serious infection like meningitis, up to dose of 2 grams every 12 hours. If it's a gonorrhea infection, 250 milligrams IM, one-time dose. ADR stands out for ceftriaxone because it can cause pseudocholelithiasis and cholecystitis because it basically binds with calcium and forms crystals, therefore precipitating in the lungs and the kidney. In this case, especially for elderly folks or young patients, you would refer to cefotaxime instead because cefotaxime can cover meningitis as the other alternate option. Category B, good for gram-positive and negative. Still, we haven't seen coverage for pseudo or anaerobes in Ceph except for the second generation. Anaerobes,
I
right?
said pseudo.
No, I said anaerobes.
Oh,
Pseudo we haven't seen yet, right?
we have
For which one?
Cetazidine.
Yeah, but I was in there.
Oh, okay.
I was saying so far we haven't seen pseudo, but anaerobes we did so far in second generation.
What do you mean we haven't seen pseudo?
Cephalosporin?
Just the
For
first
Ceph,
one.
yeah,
Oh,
yeah.
okay.
Sorry, so we haven't seen pseudo coverage for the cephalosporin yet. Anaerobes for second generation. This is used for lower respiratory infection, SSTI, BID, bone and joint, as well as meningitis, which is what we should know, gonorrhea and UTI. Last drug, ceftazidime, is interestingly different from all the other drugs in the same generation of its own. Can cross the BBB, 1 to 2 grams every 8 to 12 hours. No renal, hepatic, or is that right? No renal, hepatic adjustment required.
I
So,
don't have it, yeah.
huh?
I don't have anything. Yeah.
Okay. ADR is the same side effects as ceftriaxone. Now, ceftazidime can only cover gram-negatives, including Pseudomonas. Now we've finally seen Pseudomonas coverage for cephalosporins. But what is the loss? The loss is that we don't cover gram-positive now. No MSSA, no streptococci, no anaerobes. So we also lost anaerobes still. And so ceftazidime is really good for Pseudomonas.
So let me ask you a question.
Fortas is a brand name.
So for the class, you can't do it on the ESBLs or just cephalosporin?
The class for cephalosporin you cannot use on ESBLs. ESBLs is extended spectrum of beta lactamases. So basically, the beta lactamase expands itself and able to build resistance to more drug classes, and stuff is not a good choice
For the whole class, you said?
for the whole class. Yeah, for third generation, I believe. I think for third generation. Because I think you can do it in fifth generation. I can't recall. We'll get there. I apologize.
I mean, I don't have much to add. Just know that ceftazidime this is the only cephalosporin within the third generation that covers Pseudomonas. He talked about the ceftriaxone and having problematic when being given to neonates or geriatric, and that's because it interacts with calcium-containing foods and precipitate in the lungs and kidneys. It can also lead to biliary lesion with causing hyperbilirubinemia. That's why I guess you can kind of correlate that with the side effect for the ceftriaxone, because the side effect is what pseudocholecystitis and cholecystitis. Those side effects actually stand out a lot. So
With
Make sure-
ceftriaxone and which one?
ceftriaxone, ceftazidime.
Because when we say it binds to calcium and forms crystal, it's basically literally forming this like little solid precipitate that basically blocks the biliary tube pathway, where bile acid basically or bile comes out from the bile the gallbladder, like not gallbladder, the
What's LRI?
Ciliary duct.
yeah, the ciliary duct, but I forgot where bile duct is stored. So when that gets blocked, then you have a rise in bilirubin, and that's how you get hyperbilirubinemia. That's you can see that with your skin turning yellow, your eyes turning yellow, and other things.
The last thing within this class that I want to mention is the Avicast ceftazidime with avibactam that actually gives us a unique coverage that we haven't seen before, and that's what
Which one?
Avicast. It treats one.
Oh, Avicast. That's the combination, right, for third generation.
Again?
Klebsiella producing
Yes.
carbapenemate.
Yes.
So there's a third generation drug that's a combination that's not on here, but it is. What's the combination?
Ceftazidime with avibactam.
Ceftazidime with avibactam. Avibactam is a beta lactams inhibitor. With that combination, you're able to treat
Klebsiella
KPC.
pneumonia, carbapenemesis.
Yes. Just a side note.
Not a side note.
She's
Full
not
note.
right?
100% full note, guys. Hear that?
Right.
Ceftazidime has to be adjusted.
Ceftazidime.
The only one that doesn't have to be adjusted is ceftriaxone in regards to renal.
Both don't require renal adjustments.
Which one?
Ceftazidime and ceftriaxone.
Right.
Let's look it up. My grandmother said.
All right, guys. Look up the renal adjustments required for ceftazidime online.
What does that slide say?
Huh?
That slide says no renal adjustment.
Yes, I believe so. Because that's where I copied it from.
Where did you get that one?
I probably got. Let me see the book.
It says in the book and in the antibiotics, the only cephalosporin that needs renal adjustment is ceftriaxone.
So, which means that ceftazidime doesn't need it then, right?
It would. It was saying like the only cephalosporin
That requires adjustments is.
that does not require renal adjustment. Everything else requires
Yeah, it
renal
does.
adjustment besides ceftriaxone. I don't know if this is reliable, but it says the dosage adjustment with online it says
You do
ceftazidime has
adjust
it.
for renal.
For ceftazidime?
Ceftazidime, right?
Basically all cef except ceftriaxone for renal.
That's what she's saying.
The only exception is ceftriaxone.
Ceftriaxone, you mean?
Hmm?
What is it? What's the
Ceftriaxone.
This
So
one?
yeah, that's the only one that you don't have to adjust renally. That's the only cephalosporin.
Rosufin, is that what she's talking about?
I can't.
Yeah.
Spell the
Yeah,
drug for me.
Rosufin.
That's what's on the.
Yeah.
And that's the one that causes the kids stuff.
Right here.
Oh, ceftriaxone.
Yeah.
Oh,
I made
yeah.
it into a cream. It's a little.
I'm like, what drug is she talking about? I mean, I
Where
can't
is
pronounce too.
The triaxone.
Ceftriaxone.
Triaxone.
Try.
Triaxone.
Try for 3.
And all the T's cross the BBB.
Mm-hmm.
All the T's cross the BBB. for the cephalosporins.
Yeah.
Ceftriaxone,
Triaxone,
cefotaxime, ceftazidime. Yeah, she's right. Which ones are approved for meningitis?
the ones that-
Cefotaxime and
All the ones
ceftriaxone.
that with the T.
The ones
Yeah,
that cross the BBB
But it
though.
says don't approved for treatment for. I mean, yeah, you can treat it, but it's not. I don't know. But I have ceftriaxone and cefotaxime.
What about
Gladro is in
ceftriaxone?
I would tweak it.
Because it crosses the BBB, doesn't it?
It does. Ceftriaxone. I don't know if it's approved, but it does cross the BBB.
Ceftriaxone.
Ceftriaxone, cefotaxime, and ceftazidime. You can use ceftriaxone and cefotaxime.
It may
It,
not
mi-
be
it,
approved
it might be the
for
fact that it can only cover gram negative.
Yeah.
Maybe.
That it,
Yeah, I'm not sure.
no.
We don't talk about this. So. All right.
Okay, so ceftazidime does require renal adjustments, whereas ceftriaxone doesn't because it can go through both hepatic and renal. So therefore, it gives that kind of other pathway of escaping renal adjustment. Oops.
I should tell you she likes black guys.
Okay, next generation, we have fourth generation. Cefepime, Baxapine, 1 to 2 grams every 8 hours. IV and IM is the form. Renal adjustment is required if the creatinine clearance falls below 60. Category B, it is good against gram-positive, MSSA, strep, gram-negative, and pseudo. So now you can see that from the last one we talked about ceftazidime, we've kept the pseudo. Now we've added our gram-positive back. It's still poor against anaerobes, except for the second generation of Cefs, those two specific drugs we talked about, and it's still not active against MRSA. Side effects, uses. Use is good for neutropenic fever, nosocomial infection, meningitis, as well as UTI. But know that 4th gen is primarily used for nosocomial infection because of the fact that it can cover pseudo, and pseudo is a very infectious disease. 5th generation, known as anti-MRSA. So now we finally get to the MRSA.
Hold on.
Oh, go ahead. Oh, sorry. There's only one drug. I was like,
So cefepime is the broadest spectrum. So the way to describe cefepime is it has the first generation gram-positive activity, meaning that it has an excellent gram-positive activity, and it has the it has the third generation gram-negative activity. So you're getting the best of both worlds. Also, this drug gives us Pseudomonas, just like ceftazidime. Yep. Nephrotoxicity is seen in patients. If you see nephrotoxicity, then you have to dose adjust it at 60. One of the side effects is also mental status, and I think for those that have lab tomorrow, they'll see this. You guys will see where this comes in.
they might get a different lab.
You said what? Yeah.
Because last week they had a totally different lab
Yeah, she's
assignment.
But you will see the significance of nephrotoxicity when you're dosing, when you're actually like dosing it, and when you're actually like looking at your antibiogram or whatever the case may be.
What'd you say? Repeat the statement you made.
Which one?
The one you just made before the lab statement.
Cefepime caused altered mental status.
And you dose adjustment. You do renal adjustment at 60. So keep that 60. So we had 30, 40, now 60.
But
was
from penicillin.
Who cares? You're renal adjusting. You should.
I know, but the ones she gave us criteria for, that's one that we should know.
We have to know it. We have to know it.
That's what I'm saying. So that's the one. That's from the penicillin. So
Yeah.
it was adjustment for 34 aminopenicillins. Then automatically the beta lactamase combination 30. Then we have 44. Then we have 44 anti-pseudo, and then now we have 60
What was 40? What was 40?
anti-pseudo.
Huh?
Anti-pseudo.
Dosing and Tementen.
Isn't it for third generation cephalosporins too?
Oh, and so yeah, but I don't know what the.
We don't have a number, so that's why we didn't keep.
But there is renal adjustment for the third generation, except for the ceftriaxone.
Ceftriaxone. That's the only one that does.
Ceftriaxone.
No L.
Ceftriaxone.
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 5th generation.
And I know I said lockers, but damn.
We said locker rooms.
And then the 5th generation is 50. Repeat that.
Okay. Oh my. Did I leave my charger?
I have one.
Is that it?
Uh-huh.
5th generation anti-MRSA, Taflero, generic is ceftaroline, 600 milligram IV every 12 hours. IVIM is a drug formula. Renal adjustment is required if the CL is below 50. Adverse effects: headache, insomnia, GI. Note that insomnia is interestingly different from the rest of the side effects that we've seen so far. Category B. Now, the coverage is good against gram-positive, MSSA, MRSA, vice versa, and also the same gram-negative coverage as ceftriaxone. It is useful against SSTI, CAP, which is community-acquired pneumonia, as well as secondary bacterial infection. Go ahead.
So again, this is the only drug so far that we talked about that gives us MRSA. So this drug is particularly good against Visa and Versa, and has a similar gram-negative activity as the ceftriaxone. Visa is vancomycin intermediate Staph aureus, vancomycin resistant Staph aureus. So this is the big gun. So this is like you
This is big boy.
yeah.
Can't rely.
One of the things that stood out to me with the ceftriaxone is Taflero is the side effect, and that's insomnia. Insomnia was a big thing with this, I think.
Mhm.
Right?
I agree.
Yeah. So insomnia was the thing that stood out to me in terms of side effects. And that's it.
So now, before we go to carbapenem, you can see that in the penicillin generation, anti-pseudomonal was like the last one we talked about that covered almost everything. Ceph, same thing. 5th generation anti-MRSA covered almost everything. So the same trend.
Did anti-pseudomonal cover MRSA?
No, it didn't, but like the same concept. I think that the last category we talked about, it almost covered everything that the other one didn't cover.
Mm.
But MRSA was yet. Now we've seen MRSA here.
Did y'all say that the ceftaroline doesn't cover pseudomonas?
Yeah.
So it has
Yeah.
like third generation coverage like ceftriaxone.
Mm-hmm.
Ceftriaxone.
Mm-hmm.
I don't get it.
It doesn't cover pseudomonas, but cefepime covers pseudomonas.
Cefepime?
So that
fourth generation.
cefapime's coverage is like ceftazidime, but it has that pseudomonas coverage.
Because only ceftazidime gives you pseudomonas activity. So this is saying it doesn't want to say that it has third generation coverage because it doesn't give you pseudomonas.
Hmm.
So she's saying this is like ceftriaxone, which is a third generation but doesn't have any pseudomonas coverage.
Okay. So 5th generation basically carried over the 4th gen except minus pseudomonas.
Yes.
Okay.
And he added MRSA.
Yeah, and MRSA, yes, that's a
So
new
it
thing.
took
Yep.
away Pseudomonas and added MRSA.
Yeah.
So the only Ceph that covered Pseudomonas was the fourth.
And third. Third, we had one drug that covered it.
Ceftazidime, remember?
That's the point Lorna was trying to make.
Right here, ceftazidime. That's the
That's the only one
one that stood out the most. That was weird from the rest of his
Fourth.
brothers and
The force
sisters.
of everything.
This thing's in his force.
Nobody remembers that, man. So let it go.
I bet you're gonna remember it. It is force of everything.
Okay.
What do you say that for?
Now we also have monobactam. Well, okay, carbapenem. We're gonna finish our beta lactam with this. This is our last beta lactam drug, as well as monobactam. Monobactam meaning mono means only one ring. Aztreonam, Azactam is the brand name. IVIM is the drug formula. Renal adjustment is required here. There's no cross-allergic reaction except for ceftazidime because they have very similar structures. Therefore, if you're allergic to ceftazidime, more than likely you'll be allergic to monobactam. Otherwise, if you're allergic to any other drug of beta lactams, monobactam is the drug that you will be on because of allergic reaction. Category B is good against pseudomonas and gram-negative, but it's not good against gram-positive nor anaerobes. So it's used for aerobic infections that are gram-negative.
What?
Aerobic. It covers what?
What? Carbapenem?
No, monobactam.
Oh, you're talking about estrone now?
Yeah.
Oh, no.
Okay. That's it for me for monobactam.
Are you okay? So are you doing carbapenem or are you doing monobactam?
Monobactam.
Okay.
I'm done.
Okay.
What's the takeaway for monobactam with that one?
We see Pseudomonas now here, and it's only gram negatives,
And the cross.
no gram positive.
This is the only one you can use for process sensitivity.
Yes.
What's cross sensitivity mean?
I guess they're allergic to penicillin, but you can use aspirin.
So this one, yeah, I mean, there's not much to say. You can get, you don't have anaerobic coverage. The only thing you got is gram negative coverage and Pseudomonas. But you get that cross sensitivity with it.
So the only anaerobic coverage is in the over here is just the combination drug, right?
No, there's
The
more.
ones with the
No more.
beta lactamases. Who else?
No more. You tell me, go down the list.
Yeah, Eucin, Zosyn.
Okay.
Those all had the beta lactamases.
Okay, what else covered anaerobes?
I don't know.
Second generation.
Second generation stuff. Okay, continue now.
Oh yeah, the cephatitan. Okay.
And what's next?
And you actually should go up and go to your penicillins because we had anaerobic coverage there too. Right?
Said it.
What you said it?
No, he said Tementa and
Zosin.
he didn't say that.
That's what I did. That's what I started
You
with.
didn't say ticarcillin.
Oh.
So anti-pseudo, ampicillin and beta-lactamase inhibitors combination, second gen cephalosporin, and then
And then we also got third gen, one of them. Which one? Yeah, the force of everything, ceftazidime. And then we got Pseudomonas.
No, ceftazidime is poor against anaerobes.
No, I said Pseudomonas.
Oh, I was talking about anaerobes.
oh, so but we didn't finish anaerobes. So now anaerobes we add now monobactam.
Yeah.
So and now Pseudomonas we got anti-Pseudomonas,
So Fortas,
ceftazidime,
Cefepime.
cefepime, maxipime, yup, and now also monobactam as well. Okay, carbapenem, the last drug of beta-lactam. We have four. We have imipenem celastin combination because imipenem cannot survive on its own. Premaxin is a brand name. 250 to 1,000 milligram IV every 6 to 8 hours. We have meropenem. Merum is the brand name. 500 to 2,000 IV every 8 hours. If you look at the dose from imipenem celastin to meropenem doubled. And ertapenem Advance is given IV or IM, 1 gram IV daily. The only drug so far that we see in this class that's given daily, once daily, compared to the rest. Doripenem, Doribox, is 500 milligrams IV every 8 hours. If you look at the dose from ertapenem got cut in half. Renal adjustments is required. Side effects, nothing interesting. It's a beta-lactam, so you're going to see seizures, skin rashes. Infusion reaction for basically any IV because that's just a regular response when you give IV. Category B is good against MSSA, strep, anaerobes, enteric gram-negative rods. Enteric gram-negative rods is the same thing as saying Enterobacteriaceae family, which includes the spice A. Pseudomonas as well, Acinetobacter and Enterococci, and extended spectrum beta-lactamases. One thing you have to know is that ertapenem, E for exception, cannot cover 3 of these coverages: Pseudomonas, Acinetobacter, and Enterococci. This category of carbapenem is good for nosocomial infection, which is pneumonia, meningitis, SSTI,
What's
and some
SSTI?
other infection.
Skin and soft tissue.
Alright, Paulus.
Yeah, I mean, I don't have much to say. Just know that ertapenem is the exception. No PAE. PAE standing for Pseudomonas, Acinetobacter, and Enterococci.
What?
Pseudomonas, Acinetobacter, and Enterococci.
Oh, the exceptions.
Again, you're gonna get an anaerobic coverage here. You gain an anaerobic coverage here. Your carbapenems are just, I mean, these are your last line drugs, so you expect them to cover a whole lot of things. Imipenem is administered with cilastatin because of the DP, because it's an inhibitor of DP. So there's 2 caveats with imipenem. Now, one is you have to dose it with cilastatin because of the DP, and 2 is imipenem actually causes the highest incident of seizures.
What is DP?
Dihydropeptidase or something. They're all cleared renally. So I think you do have to make dose adjustment, and I think it's a 50, but I'm not sure.
So dihydropeptidase basically breaks down imipenem. So therefore, psilocin is administered in combination to inhibit the dihydropeptidase from breaking down imipenem and making it inactive. As well as seizures is a side effect for all beta lactams, but in carbapenem specifically, imipenem has a really high seizures is seen in a lot of cases for people who are on imipenem.
I think it's a 30, not 50, but don't quote me on this one.
Okay. And that is all of our beta lactams for the first video that we're creating.
Clap for them.
Let's say pause. Alright guys, again, use this video at your discretion. Double check with your notes and with lectures and
Correct
slides.
us if we made any mistakes. Let us
And
know.
yes, let us know if we have any mistakes, any issues, anything that was incorrect. Email us, let us know. Again, this is me. Pause in the background. Good luck on tomorrow's quiz.